Welcome to the Pain Medications, a Pharmacist Perspective webinar. Thank you for being here today. This is the 6th webinar in our series, Chronic Pain, Improving Life While Living It, and we're very glad to have you all here today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is co-sponsored by CIRPD and Pain BC in collaboration with the Canadian Pain Coalition. It's also made possible through the support of the Direct Access Program through the BC government. As I mentioned, my name is Tanya and I'm moderating today. We also have online Lisa Mighton, our education coordinator, and she'll be collecting questions and summing them up for the question and answer portion. And our presenter today is Edward Dillon. Dr. Dillon is a clinical pharmacotherapy specialist in intensive care at Surrey Memorial Hospital and a clinical professor and the Faculty of Pharmaceutical Sciences at the University of British Columbia. He worked in palliative care for 6 years at Shaughnessy Hospital, and then after receiving his doctorate degree, worked in the emergency room at the Royal Columbian Hospital for 25 years, dealing with acute and chronic pain issues. At RCH, he was also the palliative care pharmacist on the RCH palliative care team for 5 years. In the intensive care unit, he currently sees many patients with both acute and chronic pain issues. Thank you for being here today, Dr. Dillon, and I will hand it over to you.
Thank you very much, Tanya, and good afternoon, everyone. The intent of the presentation, based on discussions with CIRPD, is I understand that a large number of individuals are from the general public, and therefore the presentation was primarily geared towards them. So with that in mind, what I'm planning to do over the next 45 minutes, I'm trying to advance the slide, but it's not being successful. Let's see here.
Sometimes using the arrow keys on your keyboard will do it.
Yeah, I've tried that. It's not going forward or backward. And I'm hitting the enter key. It's not doing that either. Let's see if I can hit the arrow down here. Ah, here we go. So over the next 40 minutes or so, I'm going to provide you with my objectives for the presentation, putting the pain medications in perspective as far as overall pain management options, talk a little bit about the non-pharmacological approaches, then concentrate on the drug approaches, the pharmacological approaches, and then wrap up with some principles of use. Hopefully that would be helpful. So initially, my objectives for you, by the end of the presentation, you should be able to list the 4 treatment options for pain management, list 4 types of pain, and list 3 major classes of pain medications, and know at least 1 drug of choice from each of the classes. And then list 3 benefits or 3 concerns for each of the major classes of pain medications. So it's important, I think, when it comes to medication management options, overall pain management options, to realize where does the analgesics or pain medications fit in that whole picture. When you've got somebody presenting with pain, one way of treating the pain would be to remove the cause or modify the pathological process. So you can imagine having a cancer, a tumor in which it's swelling and causing some discomfort. Again, radiation or chemotherapy or debulking the tumor with surgery can certainly remove the causative agent in that particular case. Another approach would be interrupting the pain pathways. So using anesthesia or surgery to do that, and our dentist colleagues certainly use this quite often. Here's a schematic of the central nervous system, the nervous system in general, and just to give you some orientation, here on the left would be the skin area in which you've got mechanoreceptors, and most notably the nociceptors or pain medication fibers that would be picking up the pain signals. And usually when you have damage in this area, there may be other chemicals that are released in the area sensitizing these free nerve endings to pick up the pain signal. The signal is then transmitted through the the A delta and C fibers into the spinal cord, and then there are various pathways that would send the signal up to the brain for perception. And as you can see with the scalpel blade, interrupting the pathway has the potential of stopping that pain signal from coming down. I mentioned the dentist, so giving anesthesia at the site where the pain is being generated may also prevent that signal from being generated and sent to the brain. In addition to that, there's also feedback coming down from the brain that could dampen the overall response signal that is being detected. So for example, on a good day, you're feeling well. If there was some pain stimulation happening, you may not react to that pain stimulation as badly as if you were on a good day. So if you have an overall bad circumstance to deal with and you have pain, you might feel that pain a lot worse than if you're having a good experience for the course of the day. So culture, the psychological nature of the patient, there's a number of other factors that would play into the final perception of what that pain may feel like. A third approach to pain management would be simply immobilization. So the arm is more painful on movement, the joints may be more painful on movement, so in the case of the arm, putting it into a sling, or if you've got a fracture, then a stent, rather than a splint rather, could immobilize the movement of the loose fragments of bone and tissue that might be getting irritated all the time. And finally, the fourth general approach is to alter the pain threshold. So you're not really removing the cause, you're preventing the amplitude of the signal to getting back to the central nervous system from being detected in a very severe way. So analgesics or pain medications do fall into this category, and there's a number of other non-invasive techniques that I'll be talking about as well to put things in perspective. So removing the cause, in some cases if you've got an antibiotic, you've got chest pain, removing the bacterium that might be causing the problem, that's certainly one approach. When it comes to pain, with pain medications, analgesics, again, you're adjusting the pain threshold. And really, optimally, particularly when you've got really severe pain, using many modes of interventions, more than one, several, whatever needs to be optimal for the pain management is ideal in most cases. So some of the non-pharmacological options are listed here on the next two slides. If there's weakness and there's a need for stabilization, exercise can certainly help in strengthening muscles and therefore not allowing things to be loose, if you will, and reduce the amount of pain that may be happening from things not being articulated in the right way. Biofeedback, learning to sense what's happening in the body and reacting appropriately to it, somewhat being able to centrally control things may be of some benefit. Hypnosis, distraction technique as well. Many of us as parents have used distraction technique with our kids in order to reduce the amount of anxiety and nociception and pain that may be experienced by distracting the individual. Therapeutic touch is another way of elevating the pain threshold and reducing the amount of pain perception. Transcutaneous electrical nerve stimulation, or TENS, is another way. Applying heat or cold, heat particularly to increase the circulation, cold when there's a lot of inflammation and swelling that's going on, and of course massage as well to try and increase the circulation to an area. Again, these are all things that can be done that may benefit the individual experiencing pain. Now, there are many ways that you can classify pain. For me, just being very simply approach, I have 4 types of pain listed here. It's helpful for me to be able to delineate which category or which number of categories that the pain actually actually is behaving like. One type of pain could be classified as visceral. Viscera in the body are the organ systems that are involved. So a classical example is the heart. Because the sensitivity or the sensing from viscera in the body are not really localized very well, a number of different areas can funnel into a ganglion, and then the signal from the ganglion to the brain may not be as specific as with somatic pain, for example. So when we have heart pain, because of damage there, you might have pain over the anterior wall of the chest, but you could have pain down the left arm or up the jaw or radiating around to the back. So visceral pain, usually the individual talks about deep pain, deep down under the skin, so to speak, and it may be radiating or moving around, not in one spot that you can point out with one finger. Could be throbbing. On the other hand, somatic pain, more localized. If you were suffered a kick to the shin or some trauma operation, then the lesion is quite specific. Usually individuals can point to that area quite reliably, and again, it could be a dull ache. Usually there's no symptoms such as numbness, sharp shooting pains coming on very quickly, leaving very quickly, a cutting sensation. These are all characteristic of neurogenic pain, examples of which are postherpetic neuralgia that may happen after a zoster infection, or diabetic neuropathies in which the nerve is actually damaged and compromised in some way, and the pain, rather than being able to use non-opioid analgesics, you may have to use more of the adjuvant analgesic in order to get some benefit. Whereas the visceral somatic type of pain, very well controlled with non-opioids and opioid type of pain medications. The fourth type of pain that I like to classify is psychogenic pain. And really, I remember having a patient with this complaint a number of years back presented to the ER, in which the individual had received a phone call, and the police had told her that her son had died, and she transferred the pain in the area of the jaw and the right ear where she was holding the phone. Certainly when she first presented to the ER, we started out with our non-opioid medication and opioid medications, and wasn't able to do much in the way of benefiting her. CT scans and MRIs came back showing really no lesions involved, but by way of the history, it pointed towards the psychological trauma that she had received from the bad news that she had. So again, more of an adjuvant analgesic would be required for this type of pain, and it tends to be more generalized as opposed to specific like the somatic type of pain. So the characteristics of the pain can help in determining what the nature is. One of the principles I'd like to reinforce here is the fact that particularly when you're dealing with acute pain, usually the worst pain is when the trauma has occurred, when the incident, the insult has occurred, and beyond that it tends to subside, and usually if you're having adequate treatment, things will usually be gone in 3 to 5 days with acute pain. But the principle of having acute pain that's not properly treated, people being stoic, not taking the analgesia properly, particularly for your moderate to severe severity of pain, the improper treatment of this type of pain could have the potential of going on to become chronic, more so than if it was treated appropriately. And there's a number of articles that point in that direction. Now, whether it's acute pain or chronic pain, ideally, as practitioners, we try to eliminate the pain whenever possible. Sometimes because of the side effect, depending on whether we're dealing with neuropathic pain or psychogenic pain, we may only be able to reduce that to minimal levels because of the amount of side effects that some of these other drugs may produce. So, but ideally, we're trying to eliminate the pain, prevent the pain from coming back, removing the pain memory, and we'll talk about that in the next slide, and preventing or reducing any side effects with these drugs. So just to orient you to this general concept, the y-axis or the ordinate, you've got either concentration of drug or effectiveness, and across the x-axis, the abscissa, you've got time. So if we were dealing with an oral medication, for example, you've got a headache. If I were to give you 80 milligrams of Tylenol, acetaminophen, and you've got a rip-roaring headache, you can appreciate that you may not have a lot of benefit. So there's subtherapeutic effects. So zone 1, or below this particular threshold line, is you can have drug in the system, but it may not be adequate enough to produce any benefit. Then zone 2 would be having enough drug to reduce the nociceptive stimulus that's getting to the brain, to the point where there may not be anything significant, and you're having a therapeutic benefit, or the benefit that you're expecting to get from the drug. If you're taking too much drug, then you may be still getting benefit as far as relieving the pain, but you may be getting too many side effects. So the intent is to try and keep individuals within zone 2. You're getting the optimal benefit and not getting a lot of side effects. You'll notice that when the level of the drug falls below the threshold for benefit, however, the pain starts to come back. So ideally, the intent is to, particularly with chronic pain, to give the next dose at a time before the level of the drug falls below the threshold for benefit. And by giving that, again, at the appropriate time, the patient would stay relatively pain-free or at a reduced rate of pain. The types of analgesics or pain medications that we have can be classified into 3 basic types. The non-opioids, like Tylenol or acetaminophen and ibuprofen. The opioids like Dilaudid or hydromorphone, morphine are the classical ones here, and adjuvant analgesics commonly such as gabapentin, commonly used in this particular area. So when we are selecting agents for use, basically these are the considerations that most clinicians would look at. You're looking for something that's going to be effective to relieve the pain. With the initial dosing, you might be concerned about the onset, and with chronic pain, you would also be concerned about the ability of the drug to have a fairly long duration, so you don't have to be giving the drug too frequently. So efficacy is going to be a major component in the selection process. In most cases, it's the adverse effects that are going to be deciding or separating the various classes of drugs. Because from an efficacy perspective, the opioids and the non-opioids are potentially equally effective provided you give an equianalgesic dose. Individual differences are also important to appreciate. Is the patient having poor kidney function, poor liver function, the way the drug is cleared? Is the patient on a number of other drugs that may interact with these agents? So for example, sedatives, we don't have an opportunity to sense pain by doing a lab test of some sort. We need the patient to be able to tell us what's going on. And so drug interactions, particularly CNS or central nervous system depression with other drugs, is something that I certainly look towards and try to avoid. Compliance is the individual having to take this once a day, once every 3 days, once a week, or once every 2 hours in order to maintain compliance. And sometimes the medications are only available in a certain dosage form, whether it's oral or parenterally, and that might be an issue in the selection. And cost, generally for pain medications, not a major factor, but for some patients over the years it can be, and you need to ask and find out, or if you're the patient, tell the individual whether or not that's a concern for you. So turning first to the non-opioids, these are primarily 2 classes of drugs. The paraaminophenols, which we only have one agent, and that is acetaminophen, and the non-steroidal anti-inflammatory drugs, commonly aspirin, ibuprofen, as being very commonly used for various indications. So from an efficacy perspective, as I mentioned earlier, I generally think of these agents that are pretty equally effective. The non-steroidal anti-inflammatory drugs have the ability to also reduce inflammation, whereas the acetaminophen would only be able to correct the pain per se, as well as the NSAIDs. So when I've created this slide, I've listed a dose that is equipotent in an acute pain setting. So, for example, if you were to give 650 milligrams of Tylenol or acetaminophen, that would be equivalent to naproxen 83 milligrams as a single dose. Now, I realize that there's many different types of pain and etiologies, and we're broadening the scope, and by this table, I'm not writing in stone that this is the case. There's individual patient variability as well, but for the most part, if you were to, say, have 1,000 patients in one arm and 1,000 patients in another arm, this is the kind of indication as far as efficacy that you would expect. So when I'm getting a history, if I find that somebody's been taking 500 milligrams of naproxen, and they also tried taking at a different time 650 milligrams of Tylenol, I would expect a greater degree of benefit for pain reduction with the naproxen. And I've added the codeine on this slide simply to, again, reinforce the concept of equianalgesic dosing across the opioids and the non-opioids. Obviously, the opioids, because of their mechanism of action, has a greater potential to reduce greater intensities of pain, but at lower doses of the opioids, you can get equianalgesic doses into the patient as well. Here is to simply appreciate the difference in the route of administration, whether it's a non-opioid or an opioid. What tends to happen, again, we're trying to dose a patient and maintain them in the zone 2, the therapeutic range. I wanted to point out the fact that oral medication, in addition to being convenient, usually has a longer duration above the threshold for benefit compared to the intravenous route, which generally has a shorter duration of management. You get a higher peak, but a shorter duration. You get a quicker onset with the IV. So after the first dose, if you're giving it on a regular basis, the quick onset of effect is not really an advantage, and to maintain intravenous dosing would be a disadvantage from a duration perspective in chronic pain. Again, very, very briefly, the mechanism of action for the non-steroidal anti-inflammatory drugs. There are many things that we see that they can do in vitro. Most commonly, the mechanism is to interrupt the arachidonic cascade, which is a process of inflammation, and these drugs work specifically at the cyclooxygenase enzyme level to reduce the production of prostaglandins, which from a side effect profile has some impact on the stomach being able to reduce the chances of erosions or ulcers, and the kidneys from retaining fluid in the body. So again, the specificity of these enzymes, the cyclooxygenase enzymes, you may hear of COX-1 inhibition versus COX-2. Those things can be done with general NSAIDs. There are some that are more specific for COX-2, trying to avoid the irritation to the stomach as well as to the kidneys. But again, when they're too specific, there may be problems with cardiac function and also the increased risk of stroke as well with these types of agents. So we talked about efficacy with the non-opioids. We move on to the non-opioids. The non-opioids from a side effect profile perspective, and usually the NSAIDs would have potential for producing side effects in 4 areas. The central nervous system, aspirin is renowned for causing ringing in the ears, tinnitus, headaches. For all of them, they tend to relieve headaches, but they can also cause headaches. And rebound headaches are not unusual with abuse of these agents. Stomach, again, having ulcers and bleeding is always a concern, and particularly for elderly females with prior ulcer history. Again, the need to prophylax or prevent any kind of stomach damage from happening with a proton pump inhibitor or or a prostaglandin, such as misoprostol, is something that can be used. Kidneys, again, the concern, the more powerful of these agents, of the NSAIDs, can produce the water retention, and aspirin is used for preventing platelets from aggregating, from clotting in the blood, and preventing strokes and preventing cardiac arrests. But all of the NSAIDs can potentially do this when they're in the therapeutic range. The difference with aspirin is that once you are exposed to aspirin, the platelets are prevented for the life of them, the whole 7 days, from kind of sticking together. Tylenol or acetaminophen, on the other hand, is more at risk of producing liver problems when doses are being given beyond 4 grams a day regularly. And certainly if a person already has compromised liver function, they have cirrhosis, ascites, and so on, going to a dose above 2.4 grams a day may be problematic. So it depends on the patient as to what might be done. Individual differences, age and sex could make a difference. Usually females with previous ulcers may be at a greater risk and need to be prophylaxed against any stomach problems. Heart failure, again, high blood pressure, these drugs can cause fluid retention. The NSAIDs, so acetaminophen on the other hand, would not be doing this, but acetaminophen could have some contribution to people with liver disorders. Mood disorders, again, an agent such as Indocid or indomethacin is very closely chemically related to serotonin. So again, mood disorders could be a bit of a problem with this particular agent. And headaches, as I mentioned before, and the impact on platelets with blood clotting is something that needs to be concerned about. As far as compliance, I've listed a number of drugs with a longer half-life that can be given twice a day, once a day. Naproxen or naproxen. Aleve is another trade name for that. Diclofenac or Voltaren, Soladex or Plinerol, there's piroxicam or Feldene, and Celebrex or Celecoxib, one of the COX-2's more specific agents that are used. And as I mentioned before, cost is usually not a problem with the pain medications, but it can be for certain individuals, and that needs to be taken into account. So as a general sense, I tend to use more so acetaminophen whenever I can, and ibuprofen, and certainly they can be used together. There are 2 different classes of drugs in order to enhance the level of pain control. And the concerns with acetaminophen for more liver function, for the non-steroidal anti-inflammatory drugs, more liver and stomach problems that need to be the concerning factors, and patient-specific factors would be important to take into account as well. Moving on to the opioids, again, I've listed what is generally considered equi-analgesic doses when it's given by the 2 different routes. Generally, when you give something orally, it's subjected to the stomach acidity, more is broken down, and less is actually received at the point of action in the central nervous system, or wherever the pain may be. So that it's important to appreciate that the same dose given by 2 different routes may not result in the same degree of effectiveness. But when you look at these agents, codeine is a kind of we call it pro-drug. It's not the active ingredient. The liver needs to convert that to morphine, or at least morphine or codeine-3 glucuronide, in order to produce some degree of effectiveness. Hydromorphone, a relatively pure opioid, better to use in the elderly, less of a problem with hemodynamics compared to morphine and histamine release. Demerol, again, an agent that has metabolites that could irritate the central nervous system, and people with poor kidney function, again, it would be an agent in chronic pain not to consider using. Methadone, again, a long half-life drug compared to the others that are listed there, leading to accumulation, leading to problems with dosing, leading to the equivalency that I've listed being rather muddied as a result of that. A very difficult drug to dose effectively chronically. quickly, and you really need the experts involved with lots of experience with the dosing in order to get that done effectively. But again, when you look at the opioids across the board, they're equally effective at equivalent doses, particularly at lower doses. As the doses become quite high, then some of the partial agonists like buprenorphine and levorphanol, Toluen, they tend to ceiling out, and certainly they should not be used in conjunction with other pure agonists. When it comes to the side effect profile, there are a number of things that potentially can happen. I tend to increase my doses less than 25% and definitely less than 50% from the previous day. But certainly when I have an increase in dose of less than 25%, it's extremely unusual to have the side effects, particularly sedation and nausea, from these agents. But sedation is a concern. Think of if you're going jogging, the body has to, if you've never done it before, you need to start low and go a short distance for a short period of time and build up that resistance. And I think that analogy applies here with the opioids. If you start with too high a dose, the patient becomes over-sedated, hallucinatory, they may not like the drug for the way it makes them feel, and starting small and titrating slowly based on the patient's response may allow for a better perception and a better tolerance and therefore more success potential. So again, starting these agents, you can have these things at the back of your mind. Gastrointestinal, I think most people are appreciative of the fact that these opioids can cause nausea and vomiting, and usually there's two mechanisms to that, through the balance mechanisms in the ear, as well as through the stomach by irritating the receptors in that area, causing the nausea and vomiting and constipation. The mu receptors in the GI tract, most of it is in the colon, the large colon, but this is something that tends to be a problem with chronic pain, and it depends on how mobile the patient is, how much fluid they can consume, how ambulatory they are, and other issues that, other drugs that they may be on board that needs to be considered in dosing the drug. Cardiovascularly, particularly with morphine more so than hydromorphone, more histamine release, so patients need to be conscious when they're changing posture, not to change it too quickly and start walking, maybe stand for a while, hold on to something before stepping off. Feeling dizzy, feeling the room spinning around can certainly be the case more so with morphine compared to Dilaudid or hydromorphone. And the respiratory depression, again, this is something that a lot of people are concerned about, but again, when these drugs are dosed effectively and titrated within 25 to 50% of previous dosing and allowed to get to steady state, it's not really a problem. Even people with cancer of the lungs and COPD, asthma, again, dosed effectively, it's not a major problem. Sweating can be some difficulty in interpreting. If you've got a lot of pain, you can be sweating. If you've got a lot of opioids, you can be sweating. So again, trying to get a good history and figuring out why that is would help in making the right decision with the drug. Urinary retention is certainly something that can happen with the opioids. More so the piperidines like Demerol, fentanyl, they tend to have more anticholinergic effects and can certainly cause the urinary retention. They all have the potential of suppressing the cough reflex, but again, adverse effects would tend to be your determinant of which drug to use in this class. The efficacy-wise, if you dose them effectively, they are pretty much the same. Individual differences, again, in their tolerance is something that needs to be taken into account. Morphine or any of the oral liquids that can be used, some people may have a taste aversion for them, so needing to adjust that may be important. The dosage form, those that may cause a patient may be more sensitive, even at equianalgesic doses, they may be more sensitive to one versus another. Also, when you're changing drugs in this class. There isn't 100% cross sensitivity, so if you were to change from one dose to a different drug at an equally analgesic dose, there may be increased sedation because of that lack of 100% cross sensitivity. So the need to be maybe changing to a new drug at 50 to 75% of the equivalent dose may be prudent to do. Whenever I see hallucinations or nightmares happening, with the exception of Tolwyn, I try to think that perhaps I've got the wrong type of pain as far as the diagnosis goes, or I'm using too much drug in order to get this kind of side effect. So it's a good red light that goes on for me to try and determine what am I doing, am I using the correct drug. GI myoclonus, again, with some of these drugs, patients may be sensitive and they get these twitching sensations which may wake them up at night, and when it gets to that kind of a level, they're not seizing, but they're just muscle twitching, and that may result in discomfort, a loss of sleep, not able to tolerate the pain experiences as well, and either changing the drug to something less potentially problematic would be my first choice, as opposed to adding a drug that would help to dampen the myoclonus. Other drugs on board, like phenothiazines and tricyclics, can add to the orthostatic hypotension and the sedation, of course. And there are a number of different preparations. Liquid, suppository, many people are not fond of the suppository, of course. Long-acting preparations, like the MS-Contin, Hydromorph-Contin, Duragesic, which is the patch with fentanyl, is something that can be applied every 3 days, and the buprenorphine patch every once a week. So cost would be more of an issue here for these sustained release preparations, the patches and so on, a little bit more expensive, but again, compared to other classes of drugs, not really a major concern. When we move on to the adjuvant analgesics, these are agents that were not initially designed to be pain medications. They were created for another indication, and over time they've found to be effective at relieving pain. So from an efficacy perspective, there's a lot of variability, and usually I think of these agents being about 20 to 30% effective for the management of pain compared to the opioids and the non-opioids, depending on the severity. Obviously, with mild to moderate pain, they can be quite good. They can be 100% effective at relieving the pain. The more severe the pain, they would have more challenges there. But for adjuvants, generally about 20 to 30% effective in various types of pain, and usually for a neuropathic pain. And I mentioned before things like gabapentin, which you'll see on the handout on the website later on. These are a lot more comprehensive list of agents that can be used. So the efficacy is rather variable. Duration is quite variable. Their onset is quite variable, as opposed to working within a few hours, as is the case with non-opioids and opioids. These agents may take 2 to 3 days to have their onset, and then you may not even perceive a benefit until you start weaning them down. So getting to an effective dose and then staying for a period of time, a week to 10 days to 2 weeks, and seeing no benefit from them. Sometimes when you start weaning them down, reducing the dose, that's when you will perceive the benefit that it was producing, and may have to go back to a previous dose that was producing some comfort levels in the patient. The adverse effect profile, again, is probably the major thing that determines which of these agents to use. Most of them are producing a lot of CNS depression, so sedation, drowsiness, feeling drugged, lethargic. These are all agents that are problematic. When you have neuropathic pain and you may be considering the use of valproic acid or phenytoin, again, these are agents that can induce the liver enzymes and cause other drugs to be cleared more effectively. The Nozinan or the methyltrimeprazine, a lot of problems with hemodynamics, and anticholinergic effects with Elavil or amitriptyline. So these are agents that have a number of problems associated with them, but when they're effective at relieving pain can be quite pleasant for the patients. Individual differences, again, with the anticholinergic effects. If for males with compromised renal outputs, with BPH, benign prostatic hypertrophy, again, this would be something that would be problematic. Urinary retention. We mentioned agents such as Elavil and Nozanan causing hypotension along with the opioids. Cardiomyopathy might be an issue. Again, you don't have as much reserve when these agents are being applied to maintain the blood pressure. Mood disorders, valproic acid, carbamazepine or Tegretol. We mentioned indomethacin with the NSAIDs. These are all things that would need to, could affect mood, and again, chronic pain can affect mood. They may be on other antidepressants, so these agents will certainly work in conjunction with these other agents to produce changes in your patient that you need to be sensitive to. If part of the adjuvants was a steroid, then bone marrow disorders could develop. If you're dealing with beta blockers for chronic pain related to migraine headaches. Again, problems with asthmatics and diabetics, they may be affected with the beta blockers as well as the steroids affecting glucose control with these types of agents. So a number of other concerns that these agents would provide you with, and you need to be aware of what you're adding and how that might change the patient's perspective. So the dosage forms, again, are very variable. There's some that are only available orally, some that have some parenteral or injectable capabilities, but again, this is a challenge, and they tend to be more expensive than the opioids and the non-opioids, but again, it depends on what type of dosage form that you're using. So cost may be more of an issue with these adjuvants. And when you're applying them, there's a need to have an adequate trial for an appropriate period of time, start low, go slowly, and really be diligent instead of try whenever you can to only make one change as opposed to several changes at one time. A special comment about benzodiazepines. I know some people consider benzos as an adjuvant analgesic. I know that there are studies in the 70s and 80s that have shown that they antagonize opioid pain relief, and plus the fact that they're quite sedating, and many of them have long half-lives. I tend to avoid them. Clonazepam is one example with 48-hour half-lives, so 2 days of you start the drug can be around for a long period of time, and this is something that needs to be assessed very closely rather than putting them on for myoclonus or some other side effect profile that you need the drug for. So finally, next couple of slides are dealing with the principles of use. I strongly believe that you need to listen to the patient, get their history, believe what they have to say. Remember, there's no test like a diabetic. You can check their blood glucose levels or the hemoglobin A1C. There isn't a nociceptive level. So I believe you need to keep that patient as alert as possible to hear what's going on and what changes are being made and how that change is resulting in benefit or the lack of benefit. We need to assess the pain on a regular basis, and for the patients out there, being able to be a good historian for your caregiver is important. So having a diary, and I have this mnemonic PQRST that's on the slide. The P stands for palliative or provocative. So what are the things that make your pain worse or better? Walking, standing, lying on one side, doing activities of various types. That's important to know in deciding on how to dose you as far as a patient. The Q stands for quality. So what does it feel like? Is it dull ache? Is it sharp shooting pain? Is there burning? Is it quick onset, quick offset? Is it deep down inside the body or at the surface? Can you rub it? R stands for region. So where is it located? Does it move around? The S stands for severity on a scale of 0 to 10. How bad is the pain? What's the best in the day, the worst in the day? And from a time perspective, again, the same sort of thing. Once you've taken your pain medication, how long before you start to have a benefit? How long before the benefit is at its best? And how long does that benefit last can be very helpful. And knowing the type of pain that you're dealing with and how many modalities modalities of management are you having to deal with as well to help to change things rather slowly when you're dealing with chronic pain? A specific drug for a specific type of pain. So if you're dealing with acute pain, again, a short half-life drug, a short duration drug. Acute pain, acetaminophen or ibuprofen is very good. Opioids from a hydromorphone perspective or fentanyl perspective, I wouldn't use the patch, again, because usually for acute pain it's going to be of a short duration. So how much you use will depend upon what has been used, and by way of the history, starting with roughly equivalent amounts if you are getting relatively good pain control when you start. If it's very poor, then increasing the amount that you provide by about 25%, no more than 50% would be good. And dealing with mild pain, so 1, 2, or 3 out of 10, versus severe pain, 7, 8, 9, 10 out of 10, will help you in deciding what combinations to use. So generally speaking, when it's mild, you can pretty well use a non-opioid exclusively. When you're dealing with moderate pain, then using a non-opioid with an opioid will generally be what is needed, but it depends on the patient. And usually when you're dealing with neuropathic or psychogenic pain, the need for adjuvants would be indicated. The type of drug, again, knowing particularly with the non-opioids, do you have any inflammation? If you're dealing with the opioids, are you dealing with a partial agonist or a mixed agonist-antagonist, such as Talin? These are things that would cause you to make adjustments in what type of drugs you're going to be using. Knowing when they peak to assess the drug and when to give the next dose is important. And realizing what is an equianalgesic dose for the type of route that you're using. And again, with the opioids, you're not dealing with a cross sensitivity that's 100%. So unless there is an escalation in dose, or rather an escalation in pain over the previous day's dosing, going with the 100% equivalency would probably be not the right thing to do. You need to administer drugs in a timely fashion, regularly, not going into pain, around the clock, and using the PRN doses to help to adjust where you're dealing with. And if you're dealing with incidental pain, then there's no need to adjust the regular dose. That incidental pain experience may change from day to day, and you just need to try and anticipate when that's going to happen and dose beforehand. Reassessing the effects, the benefits as well as the side effects, and making adjustments accordingly, and then stopping the drugs when you need to in a slow fashion, preferably every 3 half-lives or 5 half-lives, in order to get things done without having withdrawal symptoms develop for the opioids. Non-opioids can be stopped relatively quickly, and it depends on the adjuvant which one you're using. There are some that can produce physical dependence, and again, that would have to be done slowly. Respecting the individual differences. Everybody does not behave the same way. We're not dealing with thousands of patients, we're dealing with one at a time, and we need to listen to them and find out what is happening with them. So what I've done over the last 45 minutes or so is giving you my objectives for the session, the pain options. It's important to realize that there's many different ways of treating pain. The more severe the pain, the more these modalities need to be applied. There are non-pharmacologic and pharmacologic interventions that can be done effectively, and there are principles that need to be applied, particularly when you're dealing with the pain medications, not increasing from one day to the next by more than 50%, and ideally no more than 25%. And I'd be happy to entertain any questions at this time. We kind of whizzed through, knowing we had a wide range of clientele out there, whizzed through a lot of basic principles, but I'm happy to entertain questions at this time.
Okay, great. Thank you very much. I'm going to go ahead and hand it over to Lisa for a few questions.
Yeah, there's quite a number of questions on here, and one that's come up a couple of times is people who've heard about a need for sort of a pain holiday, a medication holiday, a need for a clean period where you actually stop all your medications, let your body have a break from having them all and starting up again. Just wanted your thoughts on that.
Yeah, sometimes that can be quite effective. One of the concerns with these drugs, because they're affecting the central nervous system, whether they're adjuvants or the opioids, is that there can be tolerance that develops. A tolerance or tachyphylaxis is having the same amount of pain but needing more quantities of drug in order to get the same degree of relief. Now, in many cases, that's very difficult to perceive. There hasn't been any studies to show that the size of the lesion, for example, is directly reflective of the amount of pain that a patient's going to receive. So a trial and error can be done. If you're weaning the drug off to be off for a period of time, and how much pain are you putting the patient in when these drugs are being weaned off? Are you going to another type of analgesia or another modality of pain? So the amount of pain that the individual is going to experience when you withdraw them from these agents is important to take into account. But certainly if tolerance is the concern and there isn't any clear indications that the lesion or the pain-producing stimulus is changed, then having a holiday period or trying to wean the drug dose down is always something that can be tried, and particularly with the conjunction of another modality of pain relief can be effective at trying to maintain or not lose the effectiveness of the opioids and adjuvant. But it depends on the patient and depends what other information is available.
Some confusion about stopping the gate at the bottom of the spine, and when you're in intense pain, is it best to take the strongest medication first or build up to the strongest, for example, with migraine?
Well, again, it depends on the history. It depends on the patient. For acute pain, severe pain, you're wanting to relieve that pain as quickly as possible. You're not wanting to develop that pain memory with the gross severity that it's producing in that patient. So when you're dealing with pain 7, 8, 9, and 10, I would still be using a non-opioid in conjunction with a very strong, when I say strong, again, saying that the opioids are equally effective at equally analgesic doses without the ceiling effects, but you're going to be starting with a dose that is going to be effective for pain relief but not effective at producing very bad side effects, respiratory depression, deep somnolence. So again, you would start with a reasonable dose based on your experience. If the patient has got a previous history of migraine and you know what kind of doses has been used prior to this particular admission or this particular visit, then using that information effectively, the non-opioids would help to spare the amount of opioid that you might need. So to answer the question, there's a number of different approaches that can be done. Having the history would be very helpful. If you don't have the history, then I would start with maximal dose non-opioid with a reasonable dose, 5 milligrams, 10 milligrams of morphine, 2 milligrams of hydromorphone, 4 milligrams of hydromorphone. Again, knowing what type of drug had been effective prior to this visit will allow me to make a decision on the dosage to start and then escalating it after I know the peak has occurred.
A question about the phrase pain bridge drugs, and they're wondering about these medications to carry you through pain spikes when it's not yet time to take their main pain control medications, and what are they, or which ones exist, pain bridge drugs?
Yeah, any of the drugs that would be listed on the handout that you'll get on the website, any of the drugs can be, quote, pain bridge drugs. What we're talking about there's two types of uses, if you will, for pain bridging. So if an individual, a clinician is trying to titrate, try to get to an effective dosing of a pain medication, then they would start with, for chronic pain, start with a regular dose and use breakthrough dosing or bridging in order to see how much total drug do you actually need in a day in order to be relatively comfortable. And so with each day passing, the breakthrough or the bridging doses are added to the regular dose in order to eventually get to maybe only one breakthrough dose a day. When you're dealing with incidental pain, so you're lying most of the time in bed or you're in a chair most of the time, and you have to get up and go to the bathroom. The incidental pain, or you're getting physiotherapy, to use the bridging doses to add to regular doses may have the majority of your time being with too much drug. So the bridging doses would only be used for incidental thing. You have to go to the bathroom, you have to sit up to eat, you have to transfer the wheelchair, you're going to physio. These are specific things that would happen, and you need to bridge that bad sensation period. But most of the time, the regular dose that you're having is adequate. So there wouldn't be a need to adjust the regular dosing in that situation.
Can the liver cure itself once it's been damaged by medications?
It depends. It depends on how much was damaged. When it comes to sclerosis or necrosis, for example, I mentioned the Tylenol or acetaminophen. When you get the central lobular necrosis, where the cells of the liver are dead as a result of the insult from the drug, no, those cells are not going to recover. If there is some degree of liver compromise because of compromise in circulation to the liver may sputter, if you will, but there might be recovery from that. So it depends on the nature of the damage, and if it's something that which the cell is dead, it will not recover. If it's simply poor perfusion for a period of time because of drugs being applied, then yes, there can be recovery. And the liver is a tremendous organ that, even though the gross indices that we would use to try and assess how good it's working, or even a gross assessment if they open up the tummy to see what it looks like, we don't have a really good way of knowing how well it can work. And there's some indexes that would say that the liver is really bad, but yet the drug is being cleared quite well. So it's very difficult to say.
A couple of questions about fentanyl. One asking about the patch, how long it should be used, is there a time when you should stop it? And another one asking if you could talk a bit about nebulized or inhaled fentanyl.
Sure. As far as the patch first is concerned, again, the application, the saturation of the skin, the changing sites, for chronic pain, it is something that can be continued for long periods of time. And the concern would be whether or not the pain is getting worse, whether there's any tolerance developing, whether you're applying it to different thicknesses of skin. Those are the kinds of concerns that would be more prominent for me. So from a tachyphylaxis, not so much. Side effects, not so much. I'm quite happy with the patch being applied every third day, and it's being adhered to the skin very well. As far as the inhalation of fentanyl, again, helpful for drying up secretions. Absorption is variable, but again, you can titrate that depending upon the dose that's being used to the effect that you're needing to. But again, you're going to get absorption through the lung mucosa, and that's something by way of inhalation that can be effective for 2 indications.
And thank you very much to Ed for his presentation. That was a wonderful and very informative presentation today. And thank you all for attending, and we hope to see you at the next webinar.